Hello, and welcome to the Dance Physio Podcast, a podcast designed to explore ideas and foster discussion around dancer health and wellness. We're here to challenge the status quo, bridge the gap between dance science and the studio, and help change the landscape of the dance industry for the better. I'm your host, Erika Mayall, a dancer turned physiotherapist who is deeply passionate about leaving the dance world better than I found it. I'm so glad you're here. Let's get started. Hello, everyone, and welcome back to another episode of the Dance Physio Podcast. I am your host, Erika Mayall. Before we dive into today's podcast episode, I just want to share a review of the podcast that somebody left for me on Apple Podcasts and hope that maybe this inspires you to potentially leave a rating or review as well. Periodically, I will read out reviews that people are leaving, so if you want to hear yours on air, please feel free to do that. But honestly, it helps so much to have reviews and ratings of the podcast on whatever platform you're listening to it on, whether that be Apple Podcasts or Spotify or any other podcast platform. It really helps other people find the podcast who would likely benefit from it as well. So I got this lovely review that says, Erika is so knowledgeable and her passion for educating and passing along that information to students and educators is contagious. Both in person and online, I have found her courses and podcasts so valuable. Thank you. Thank you so much for taking the time to write that review. Like I said, they are really helpful and powerful ways of other people being able to discover podcasts with the algorithms and all of that goes on behind the scenes that I'm not even going to pretend to understand. But I do know that the more reviews and ratings we get for the podcast, the more this information will reach broader areas of the dance community. So thank you so much for that. And without further ado, we will get on to today's podcast episode. We are going to be talking all about labral tears, hip labral tears in dancers today. And this was a podcast episode request that somebody sent in to me. So if there is ever a topic that you are interested in learning more about, whether that be an injury or a condition or a technique thing in dance or really anything goes, please feel free to send me a message, send me in your requests, and I will do my best to try and cover it at some point on a future podcast episode. So, like I said, today we're going to be talking about hip labral tears. Before we get into what those are and the causes and all of that sort of stuff, it is important to understand a little bit about the anatomy of the hip joint so that we know what we're talking about. So our hip joint is a ball and socket joint. And I think most people are probably familiar with that concept. So we have the ball, the sort of round part that is on the top of our femur, so our thigh bone. That's the ball part of the hip joint. And the socket part is attached to the side of our pelvis. So we also call the socket the acetabulum. That's like the fancy anatomy term for it, but it is the socket part of it. And so the ball and socket part of the hip joint has this labrum that is part of the hip joint structure as well. And the labrum is essentially a ring of, it's actually fibrocartilage. Sometimes we just refer to it as cartilage, but it's like a fibrocartilaginous structure. But it is a ring of this cartilage that lines the socket of the hip joint, so the acetabulum, and primarily the outer portion of the acetabulum. So when we look at the labrum, it is thicker towards the outer edges of the hip joint socket, and then it kind of thins towards the center, and it actually doesn't exist right in the very center of that ball and socket joint. So it is lining the outer rim of the socket part of the hip joint. It is, wow, there's a little bit of controversy about this, but it is considered to be primarily an avascular structure. So what that means is it generally doesn't really have a blood supply to it, although there is likely and potentially some blood supply to the periphery of that labrum. So parts of the labrum are likely avascular and parts of it probably do have some blood supply, but in general, it does not have a really great blood supply. And this is similar to, say, the meniscus in the knee, which is also sort of a cartilage part of the knee joint. it has a similar function in terms of its blood supply being primarily avascular or having some peripheral blood supply. So there is a little bit of controversy with the hip joint labrum in terms of whether it is avascular or not, but our best understanding of it right now is that there is potentially some peripheral blood supply to it, but it is not sort of significantly vascular in terms of its structure. There has been some research that's looked into whether there's actually nerve endings in the labrum itself. It used to be thought that the labrum itself was sort of not a pain-generating structure, that it did not have nerve endings, but research now shows that it likely does have some innervation or some nerve endings. So there is the potential that it can be a pain-generating structure. Maybe not to the same extent that like a muscle or something like that would be, but it does seem at this point that it probably does have some pain-generating capabilities within it. The function of the labrum, its primary function is to deepen the hip socket. So remember that it lines the acetabulum, the socket part of the hip joint, and the labrum essentially makes that socket a little bit deeper so that it can be a bit more of a stable structure. So if we have a deeper socket, we just have more stability in that joint. So it really serves a big role in providing stability to the hip joint itself. It also acts as a shock absorber. And we've talked about shock absorption lots on other episodes of the podcast, most recently on the episode on flooring and the importance of proper dance flooring in terms of shock absorption, because dance is generally fairly high impact and very repetitive in nature. We want to have good shock absorption. And there's been some research that has shown that we see increase in forces going through the hip joint of potentially up to 92% if there is a tear present in that labrum. So if there's a tear in the labrum, it loses its ability to act as a really efficient shock absorber, and we see really big increases in forces that go through the hip joint. The labrum also has a role in lubrication of the hip joint, so kind of how smoothly the hip joint can move. We rely on lubrication, similar to, our car parts being able to move properly. They need to be properly lubricated. So do the joints in our body. And so the labrum does have a role to play in lubrication. And it also acts as a little bit of back to the car analogies, a little bit of like a seal or a gasket. So it actually helps to regulate or distribute the pressure within the hip joint by making the hip joint sort of a closed loop system, for lack of a better description. And again, if we have a tear in the labrum, one of the biggest issues that arises, or one of the reasons we probably see these big increases in force and decreases in stability in the hip, is that we lose some of that pressure regulation within the hip joint. We see the same thing happening in the shoulder with labral tears. So there's a labrum in the shoulder joint as well, because it is also a ball and socket joint. And so we see that same phenomenon where we lose some of that sort of pressure regulation in through there. So the labrum is important in our hip joint, and it has a lot of different functions, but its primary function, its biggest function, is to deepen that socket, that acetabulum, to help to provide more stability of the hip joint. So hopefully that all makes sense to you, because we're going to now get into talking about what happens when things go wrong with the labrum, and specifically looking at tears in the labrum. So there can be a bunch of different causes of tears within the labrum. Certainly they can happen from traumatic events. And in a non-dance population, these are often from things like car accidents or I'm trying to think of like one that I've seen recently in clinic. Skiing accident. So somebody who had a fall with a ski didn't pop off, leg got yanked one direction. You get the picture. So we can certainly see labral tears happen with traumatic incidents. And in a dance population, that could be somebody dropping down into a split suddenly, or potentially even like kicking their leg and all of a sudden they feel like a sharp, okay, something just happened in the hip joint. So we can have these tears that happen in a traumatic fashion, but they can also happen in more of a repetitive, sometimes we call these like wear and tear or degenerative, but they're happening from repetitive motions over time that is causing some sort of issue within that structure. In dancers in particular, these repetitive motions are often happening at extreme ranges of motion. So we're working often in external rotation, in turnout, or in a lot of hyperextension within the hip joint and in these kind of extreme ranges of motion or just extreme ranges of like flexion or abduction or any of those hip motions, depending on what we're doing, if we're kicking or we're doing splits or we're doing whatever. And so those repetitive motions at extreme ranges of motion are potentially more likely to cause wear and tear within that hip joint, which could in turn lead to some degenerative tearing happening within that labrum. Labral tears can also happen with people who have underlying structural issues within the hip joint. And the two most common ones that we see are people who have some degree of hip dysplasia. And this is often going to be diagnosed at birth or like in infanthood. It is one of the things that they do actually screen for in infants is hip dysplasia. And if it is present in an infant, they will often intervene when they're young and they'll put them in this special brace that they'll wear for, well, depends, but, let's say 6 months or that type of thing to try and address that dysplasia that's happening as the baby's growing. So if somebody does have hip dysplasia, they may be aware of it because it might have been something that they were addressing as they were an infant. But in more mild or subtle cases of it, it may not have been identified as an infant. And so we may have dancers who do have an underlying kind of shallow hip socket or dysplasia that's going on in through there that they are not aware of because it was not something they knew about in infancy. We potentially see higher rates of hip dysplasia in the dance world because it often lends itself to increased ranges of motion into external rotation. And so that is our turnout. And so somebody who maybe has a degree of dysplasia going on might find that they naturally have a lot of turnout. And so they might have been sort of drawn to dance, or if they were introduced to dance, they may have been more likely to stick with it because that part of dance came more naturally to them. So it's certainly something that we do see in the dance world, and people may or may not be aware of the fact that they have it. So the presence of dysplasia definitely increases the risk of people developing tears within the labrum. And again, these are going to be those like repetitive, or I don't love the word like degenerative because it just sounds awful, but wear and tear type tears that are happening in the hip labrum. The second type of structural change that is common and often leads to tearing within the labrum is what's called a femoral acetabular impingement. And so this is people who have I'm going to say abnormal bone development on either the femoral head or on the rim of the acetabulum itself, where there's a little bit of like overgrowth of that bone. And so when they come into certain positions of the hip, those are going to impinge against each other or pinch against each other. And that impingement can actually lead to tearing in the labrum. Again, we see higher rates of femoral acetabular impingement or FAI in dance populations because of those extreme ranges of motion that we use. So we are more likely to get impingement happening when we're using really extreme ranges of hip mobility. We also can see hip labral tears be more common in people who have more laxity in the hip joint capsule. So that's kind of like more stretchiness or just less stability in the hip joint capsule. And we just talked about the labrum being really important for stability, but likewise, if we don't have as much stability, the labrum is going to be under more stress and potentially more likely to sustain a tear. And we see that happen in dancers who potentially have some sort of underlying joint hypermobility and or maybe a connective tissue disorder like Ehlers-Danlos syndrome or something that's leading to joint hypermobility or joint instability. We potentially see an increased prevalence of tears with increasing age. So these are injuries that we don't often see as much with younger, like adolescent dancers, but in a more retired dance population, for instance, that might be where they're showing up. And so we may have older dancers or retired dancers that are presenting with these hip labral tears, and they're probably a result of what they were doing when they were younger, but we don't often see them present as young. Although I will say in my clinical practice, I am seeing a trend, and I know some of my dance medicine colleagues, we've talked about this before, that we are seeing a trend of these labral tears happening younger and younger in dancers, where it used to be that I almost never saw them, or in fact, I don't think I had ever seen one in a younger dancer. It was always something that we saw in, dancers towards their end of the career or potentially once they were retired, but we are definitely seeing these labral tears a lot more commonly in younger populations now. So just something to keep in mind, something to think about. I have lots of thoughts about why that is the case in terms of the more extreme ranges of motion that we are using and more extreme overstretching practices and all of that is happening within the dance world. But that is perhaps a podcast topic for another day. There does not tend to be a huge difference in terms of rates of tears with gender, like male to female. There maybe is a slight predisposition for females versus males, but that's not super conclusive or super obvious in the research. It does seem to be something that is distributed relatively evenly. If we look at dance research, then potentially we're seeing a little bit more in females, but there are just in general more females that dance than males anyway. So that's probably not necessarily a good indication. So in terms of sort of causes of labral tears, the main ones that we see are either trauma or these kind of wear and tear type tears that are potentially related to underlying structural issues, the repetitive motions happening, especially at extreme ranges of motion, and then increased laxity or a decrease in stability that is present at the hip joint. In terms of how do these present, what are dancers going to report? What are they going to feel? So we call this signs and symptoms. I want to preface this by saying that a lot of these, in fact, almost all of these signs and symptoms, or the things that present or are classic with a labral tear, are very, very common with other hip joint pathology as well. So with hips, a lot of what's going on, and whether it's a muscle strain or a bursitis or a labral tear or what have you, snapping hip syndrome, whatever it is, the signs and symptoms are almost all identical a lot of the time. So if you're listening to this podcast episode and you're like, oh my goodness, my hip does all of those things, that is absolutely not conclusive of the fact that you have a labral tear. If you do have pain associated with that, you probably do want to go get that evaluated, and ideally by somebody who understands dancers, but it is by no means conclusive that you have a labral tear because, like I said, it really does mimic almost every other hip joint pathology that can happen as well. So first of all, in terms of signs and symptoms and what we see, a lot of, and we don't have an exact number on this, but a lot of labral tears in hips are asymptomatic. So they've done imaging studies where they have looked at, sporting populations and the general population and dancer populations and kind of compared, and they've used diagnostics like MRIs and things to look, and they find high rates of labral tears in completely asymptomatic people. So it is one of those things that just because there's presence of degeneration or a tear within the labrum does not mean that functionally it is a problem. So this is not something that we recommend everybody rushing out and getting imaging done or anything like that, because if it's not causing any issues, then we don't do anything about it, and we could, potentially consider it to be something that is just a normal sign of, aging wear and tear within the hip joint. For people who do have symptoms, one of the most common things that we will see is pain in The hip, most often the anterior hip, or sometimes people will describe it as being like deep within the groin. Sometimes with labral tears, people have trouble describing where the pain is. They'll sort of say, I don't know, it's just kind of there, as opposed to other hip issues where they may be able to pinpoint it more particularly to the outside of the hip or the back of the hip or the front of the hip, or like very specifically be able to locate it. With labral issues, sometimes it'll kind of present as more groin pain, or they will just often be like, I don't know, just somewhere in my hip, like very sort of vague. There can often be locking or clicking or catching or popping sensations in the hip. And again, these are really, really common in a whole bunch of different hip pathologies. But one of the things that might lead us to think, okay, maybe the labrum is more involved versus other types of issues in the hip is the sensation of it like locking up in certain positions. So it's not just that it like cracks or pops when you go to like move your leg in a certain position, but it might feel like it kind of like catches or gets stuck or locks in a certain position. So that can be an indication. We will often see stiffness or limited range of motion within the hip, and this again can be in particular movements. So very commonly we'll see internal rotation or adduction, so moving the leg across the body. Those will often be quite limited and like sort of stiff and painful in there. So there can be other signs and symptoms, but those are the most classic ones. But like I said, those are also very, very, very common with all sorts of other hip issues. So labral tears can sometimes be a little bit tricky to diagnose because we often are ruling out other things that are going on in the hip at the same time. So it is not an injury that is super easy to self-diagnose using Dr. Google or those types of things. More often than not, we will involve imaging if we've done an evaluation and we suspect that maybe that is something that may be going on. In terms of prevalence or incidence, we don't actually have really good numbers on this, and especially not within the dance world, but even within the general population. This is not something that we have a lot of good sort of data and research. There's been a couple of studies that have tried to look at it, but it's not something like some injuries we have really good data to say like, okay, this is the percentage of populations that experience this, or this is how common that this injury is. There was one study that was done by Sue Mace from the Australian Ballet where she was looking at hips of dancers versus other sports people. I can't remember what sport backgrounds they came from. And so they looked at both hips on all of their subject matters, and they found that 51% of the hips that they studied had the presence of labral tears. Now, those did not necessarily correspond to people being symptomatic. And so again, like I was saying before, a lot of labral tears can present asymptomatically, and that's potentially one of the reasons why we don't have really great research or like good numbers at this point in terms of prevalence and incidence when it comes to labral tears. I will say that just anecdotally or based on, maybe not high-level research, there is probably higher rates of labral tears in a dance population compared to the general population or potentially even other sporting populations. Although in that study that Sue did, they did not find a difference between dancers and other sporting populations. They found them to be similar. And that, like we talked about, some of the sort of causes or risk factors for labral tears with those repetitive movements, extreme ranges of motion, increased joint laxity, all of that makes sense that maybe we are going to see a higher rate of them in dance populations, but we don't really have the numbers to support that at this point. So if we do have a labral tear, what are our options in terms of treatment? Well, like a lot of injuries, we have options for conservative treatment, and if that does not work or sort of people quote unquote fail conservative treatment, and again, I hate that terminology, then there are surgical options as well. It is recommended that people undergo at least like a minimum of 6 months of intense physical therapy or conservative treatment before considering a surgical option, because a lot of these can be managed conservatively. And I think in the past, and we see this in other injuries too, like even meniscal tears in the knee or other types of injuries, it used to be common that as soon as they saw evidence of that injury on imaging, it was like, well, we have to get surgery. That's the only way to fix this. And we know now that a lot of people do very, very well with conservative treatment. And therefore, the presence of a tear itself is not necessarily an indicator of surgical intervention being required. It has much more to do with function. And if people are still experiencing pain and dysfunction after undergoing, a minimum of 6 months of intensive conservative treatment, then potentially a surgical option may be considered for them. So what does conservative treatment look like? Well, certainly there's, modified activity, rest. Some people in the past would recommend non-steroidal anti-inflammatory drugs. We've moved away from that, as you will know if you've listened to the Peace and Love podcast episode. But I'm going to talk more specifically about from like a physical therapy or a physiotherapy point of view, what it is that we're sort of looking at or what we see commonly. So generally, if we're looking at activity modification or movement modifications, what we often need to do in the beginning is limit turnout range of motion, so external rotation range of motion, and extension range of motion. And the reason for this is that those motions put the most amount of stress on the anterior or the front part of the labrum, and that is the most common area that we see these labral tears happening in. And so those might be movements that we limit. And so if we have a dancer and they are trying to continue to dance and we're modifying what they're doing, we're not pulling them from dance completely, we are often getting them to work in, let's say, 75% of their turnout, or maybe even 50% of their turnout, depending on their symptoms and how they are presenting. But limiting turnout temporarily is often one thing that we really, really need to address. And then extension as well. And so it might mean that if their leg is going to the back, it has to stay. Again, it's going to depend on their symptoms and those types of things, but maybe their leg has to stay 45 or lower, or maybe their leg has to stay on the ground. Or I've had dancers before where we're not doing any extension, not even a tendu to the back for a period of time as they are initiating or starting out their rehab. In terms of common presentations that we see, oftentimes in hip labral tears, we're seeing a lot of weakness in some of the muscles surrounding the hip itself. And whether this is causative to the labral tear or more of a kind of compensation afterwards, a pain response, I don't know for sure, but there was one study that looked at kind of strength and its association with labral tears that found that 92% of the labral tears in the study had strength deficits, specifically in hip flexion and hip abduction. And those, I will say clinically, from labral tears that I see, and not even just tears, but other hip issues that we see in the clinic with dancers, those are probably the two most common, well, that and glute strength as well. Those three are the most common areas that we do see strength deficits. And so again, 92% of the people in that study had strength deficits in those particular muscle groups. So we certainly want to work on strengthening of those specific muscles. And in the case of dancers that I see a lot of the time, it is often working on being able to utilize strength of the deep hip flexors, the psoas in particular, in conjunction with appropriate stabilization through the pelvis and the abdominal muscles and the core muscles and all of that. And so what we often see in dancers is they have developed kind of compensatory movement patterns where they are not necessarily stabilizing super effectively through their pelvis or their core, and therefore the hip muscles aren't necessarily able to activate as efficiently as they should be. So it's not just a matter of isolating a hip flexion kind of movement and doing that repeatedly over and over and over again. Oftentimes we're actually having to look at the global movement patterns and coming back to even more basics of kind of stabilizing through the pelvis and the trunk and things like that before we even start to add hip movement and hip movement strengthening on top of that. So from a strengthening perspective, like I said, definitely hip abduction, hip flexion, and especially the deep hip flexors, and the glutes. And dancers are notoriously poor at activating their glutes or using their glutes appropriately. And this can be for a variety of reasons. One of the things we will see commonly is dancers are really trying to use their glute muscles to hold their turnout, and so therefore they don't have additional power left over to support hip extension or some of these other movement patterns that really they should be kind of supporting. But we also just see a lot of dancers who are just really weak in their glutes because they'll use their hamstrings instead to achieve movements like hip extension, where it should be a primarily glute-driven movement, but our hamstring does have the ability to help with that movement. And oftentimes in dancers, we'll see them using their hamstring as the sort of primary mover for that movement and not using the glute as efficiently as it could be. So it often involves a lot of kind of repatterning or addressing some of these movement patterns that dancers are maybe used to. The other thing that we see really commonly is dancers having an over-reliance on hip external rotation, so turnout versus internal rotation. And it is not uncommon for me to see a dancer who maybe has 70, 80, even 90 degrees of hip external rotation, so huge amounts of hip external rotation, but barely gets to neutral in terms of internal rotation, or maybe has 10 to 15 degrees of internal rotation. And that imbalance in through there between the external and the internal rotators can cause huge issues in terms of the shear forces that are happening at the hip joint and potentially putting a lot more stress or pressure through one particular part of the labrum. So one thing that we were often working on a lot with dancers with hip labral tears, or again, other hip issues like impingement syndrome and stuff like that, is balancing out that movement. And so usually that involves working on internal rotation, and most dancers hate working on internal rotation because it feels like icky to them, or it just feels wrong because they're so used to being in external rotation. Also, if we have dancers who like to stand with their feet, kind of externally rotated all the time. So that's that classic dancer posture where you're like, oh, I can tell you're a dancer just by the way you stand. We want to try and encourage dancers to bring their feet more towards neutral if we can, so that we're not spending the majority of our life hanging out in those externally rotated positions. We're already going to be in those positions enough while we're actually dancing. So when we are not dancing, we do want to try and encourage more sort of full use of the range of motion at our hip joints. So definitely addressing that over-reliance on hip external rotation versus the internal rotation. Sometimes we'll actually see shortening of some of those muscles if dancers have been doing that for really long periods of time. So it might involve addressing shortening and actually really having to address the range of motion. Sometimes it's more so just training some of those muscles and reestablishing balance within those muscles. We will often see tightness, and I'm using tightness in sort of air quotes, you can't see me, but we will see kind of tightness in the TFL, which is a hip flexor muscle, so tensor fascia lata, but it's not our deep hip flexor muscle. So TFL, our rectus femoris and or hamstring muscles in through there. And this tightness, the reason I'm using it in air quotes is it's usually not a shortness or a length problem in those muscles. It is usually a tightness that is developed from those muscles being overactive to try and protect or control something else that's going on in the hip joint. So we will not necessarily work on aggressively stretching out those muscles or things like that. But as we work on strengthening the muscles that are potentially not as strong as they should be and work on rebalancing the movement and the motor control around the hip joint, we may need to address some of those muscle groups as well. And that could involve more manual therapy, or potentially I sometimes use like needling, like dry needling on those types of things. So we may need to address that as well. But generally with hip labral tears, we're not working on aggressive stretching or things like that, because usually it is not a muscle length issue. It is more often a movement patterning or motor control issue at the hip joint. And so it's all about retraining things as opposed to just stretching things out. So that just gives you a little kind of snapshot of what we might be looking at from a more conservative or physiotherapy-based perspective. And then, like I said, dance modifications as necessary. So specifically, external rotation and extension are the ones that we often need to limit, but we also may need to look at limiting repetitive movements. And so that might be, limiting how many kicks or grand battement or développés or things like that people are doing with the symptomatic side and things like that. So it's not just the range of motion that we're limiting. We might actually be looking at limiting some movements and things as well. If dancers are not successful with conservative treatment and they are still experiencing symptoms and are limited in their functional abilities, then there are surgical options available. Most of the time, labral surgery is done arthroscopically, so that means it's like they do those little keyholes. It's not a really huge, big open procedure, and the advantage of that is that the recovery times are generally quite short. They're still longer, but they are shorter than with open procedures. So arthroscopic surgery generally shortens recovery times. So there are a large variety of options in terms of what a surgeon might decide to do with a labral tear. In some cases, they might just do a debridement, which just means going in and cleaning things up. And, they don't really do anything other than if there's kind of debris floating around in the joint and stuff, they'll just kind of clean things up a little bit. And that can sometimes be very successful. They may look at repairing the labrum. If they can see that it's like a very distinct tear in a certain location, they might suture it up or repair it in some way. They may need to look at reconstructing it depending on how much damage there is and whether there is damage to the underlying chondral surfaces and things like that. Or they might actually look at augmentation as well. And so that could be looking at a much more extensive kind of reconstruction where they can do, this is almost approaching hip replacement type things, but they might look at just replacing or resurfacing the socket of the joint rather than doing a full hip replacement or things like that. So I am not an expert on the surgical techniques, but there are a large variety of them. And so I'm not going to talk a lot about recovery from surgery and surgical and recovery times and stuff because they vary massively depending on what surgical technique is being utilized. In the literature, there are reports of dancers returning to dance within 6 weeks after having arthroscopic surgery to their hip, and other research or other reports of dancers taking more than a year to be able to get back. And again, the variability just has to do with how much variety there is in the surgical techniques available. So all of that to be said that there are surgical options, but it's going to be on a very case-by-case basis depending on what they're finding with the pathology in your particular hip joint or the dancer's particular hip joint. In sports research with labral tears, there is a very, very high return to sport success rate. I don't know if that's the right wording, but you get my point. With athletes being able to return to sport successfully post labral repair or surgery, we have much less information in the dance population. And so the fact that the success rates are fairly high in sport is good and gives reason for optimism, but dance is definitely a different activity in the sense of how extreme the ranges of motion are and things like that. So that's not to say dancers can't get back to it, and most dancers probably do, but we do probably need a lot more research in dance-specific populations with these types of surgical recoveries because it is physically a different demand than most athletes getting back to soccer or, other types of sports where the ranges of motions are maybe not as extreme. All right. I'm going to wrap things up there. I think I've covered everything I wanted to say. So we talked about the anatomy and a little bit of the pathology of the hip joint and the labrum. And we talked about common causes of labral tears in dancers. Talked a little bit about maybe what some of the signs and symptoms of those labral tears are. But again, we have to take those with a bit of a grain of salt because they do overlap significantly with a lot of other things that go on within the hip joint. And then talked a little bit about treatment options and specifically what we're trying to do and optimize from a conservative standpoint or a conservative treatment point for dancers. I hope that that was helpful to you. I know, like I said, that this was a podcast topic that was requested by a couple of people. So it's been on my list for a while. So hopefully that is helpful to you. If you have questions about anything that we covered in the podcast episode today, please feel free to reach out. I am more than happy to help answer those questions. And like I said at the beginning, if you would be so kind as to leave a rating or a review for the Dance Physio podcast, I would be so appreciative. It really does help so much. So thank you all for listening today, and I hope you have a great rest of your day.